Hello, and welcome to the webinar, The Need for Concentrated and Rapid-Acting Insulin Treatments in Diabetes Care. I'm Jay Schuyler from the Diabetes Research Institute at the University of Miami, and I'm honored to be able to moderate this program. Our speakers today include Wendy Lane from Mountain Diabetes and Endocrine Center in Asheville, North Carolina, Davida Kruger from the Henry Ford Health System Division of Endocrinology in Detroit, Michigan, both of them in the United States, and Thomas Pieber from the Division of Endocrinology and Metabolism at the Medical University of Graz in Austria. The program consists of the three of them presenting successive talks. First will be Wendy on unmet needs in insulin therapy, the benefits of concentrated rapid-acting insulin. Then Davida will talk about the benefits of concentrated insulin from the patient's perspective. Always keep the patient in mind. Thomas will then give the results from Aracor's phase 1 clinical trial of its ultra-rapid, ultra-concentrated insulin product candidate, which is called AT278. We'll then have time for questions and answers. And I ask you to please put your Q&A into the Q&A button on your screen, not into the chat. We're going to monitor the Q&A for the questions, and so please put them into the appropriate place for that. And I will keep a list of the questions that I'll pose to the various panelists, and we'll go from there at the time of the Q&A. With that, and without further ado, I'll turn it over to Wendy for the clinical need. Wendy?
All right. Well, thank you, Jay, and it's a pleasure to be here to talk about this very important topic of unmet needs in insulin therapy, and specifically the benefits of concentrated rapid-acting insulin. I can advance. Here are my disclosures. So here are the key points I would like to make. First of all, the global obesity epidemic is driving up insulin doses for patients not only with type 2 diabetes, but also with type 1 diabetes. And as we know, it is obesity which drives insulin resistance and increases the insulin requirement in patients with diabetes. This has led to a need to deliver high prandial insulin doses for patients with high insulin requirements. And this includes patients using multiple daily injection regimens or insulin pen injections, as well as insulin pump therapy or continuous subcutaneous insulin infusion in insulin pumps. And right now, there is only one concentrated, and it's a U200 double strength ultra rapid insulin product, and it is not approved yet for use in insulin pumps. And there is a 5 times concentrated almost intermediate acting insulin, which is U500 regular insulin, which has been around for decades. And however, U500's insulin pharmacodynamics profile is too slow acting to control postprandial glucose levels, and therefore it can't meet the prandial insulin requirement for high dose insulin patients. And finally, the point of our webinar today is to show how a highly concentrated U500 ultra rapid insulin will improve comfort for patients who need these high dose injections, convenience in terms of not needing to change out supplies all the time, both pens and pump cartridges and pumps, and improve the cost for patients who require high insulin doses and enable the development of small, long-lasting, less obtrusive insulin delivery systems. So let's look at this. First of all, let's look at the epidemiology of obesity. In the United States, this was from 2018 from the CDC, you can see that most states, in fact, all states in the United States had almost a 25% or higher obesity prevalence, with the southern states and the Southeast up to 40% of a prevalence of obesity. And the prediction is that nearly half of Americans will be obese by the year 2030, especially if you look at the Southeast. I practice in North Carolina, halfway up the East Coast, and basically many of our patients are obese with both type 1 and type 2 diabetes. It used to be thought patients with type 1 diabetes were thin and their insulin requirements were low. But just yesterday, I saw a gentleman with type 1 diabetes who needs 220 units of insulin per day. And that's a challenge to deliver that physiologically. Here is the global map of obesity in adults, and you can see that obesity is no longer just a problem in the United States, but in the entire world. And we can see that Europe, the Middle East, Australia, South America have overweight and obesity. This is people with a BMI above 25 of over 60% now. And it is this obesity epidemic driving type 2 diabetes. We call that diabesity, but also increasing insulin requirements in heavier people with type 1 diabetes. So we know from several studies of different types that insulin doses in our patients are ever increasing. In a 2012 study, 35% of patients with type 2 diabetes needed a basal insulin dose of 60 units or more. That doesn't include prandial insulin requirements, which can be equivalent to the basal insulin requirement. In 2013, in a treat to target, again, a basal insulin study, it showed that in insulin naive patients with type 2 diabetes, 21% required more than 80 units of basal insulin by the end of the trial for glycemic control. And now market research has shown in 2022 that the average patient with type 2 diabetes requires 97 units of insulin per day. So these numbers every year are going up in terms of insulin requirement in our patients. And here are some of those data shown graphically. This is a 2011 trial on the left. And in this is all from market research showing that in patients with type 2 diabetes, a total of 595 patients were surveyed. And these were people with type 2 diabetes using either insulin pumps or injections. At that time, about 17% of these surveyed patients required more than 100 units of insulin per day. And now, fast forward 11 years to this year, 2022, and it's about 1 out of 3 patients using more than 120 units per day or more than 100 units per day. So we can see, and again, this all comes from market research of this study, 307 patients with type 2 diabetes. So we can see that insulin doses are really going up over time. And again, this is led by obesity. So as I said, obesity is no longer afflicting only our type 2 patients, but also our patients with type 1 diabetes. This was just published a couple weeks ago in the journal Endocrine Practice. And at an academic medical center, a survey of 451 patient records with type 1 diabetes showed that 64% of these patients had a BMI of over 25, and 25% of them were actually obese with a BMI of over 30. So it's no longer the case that people with type 1 diabetes are thin. They too are becoming overweight and obese, and this is driving the need for higher insulin requirements. So who are some other people who might need a concentrated insulin or a high insulin dose? Well, obviously patients with obesity, with type 1 and type 2 diabetes, as we said, but there are certain situations that also will drive the need for a high dose of insulin. Post-operatively, when patients are stressed or on steroids or on immunosuppressants, glucocorticoids, patients can have a massive increase in their insulin requirement. And sometimes it is just almost impossible to deliver these high doses well without a concentrated insulin. And patients on antiretroviral therapy who are being treated for HIV, this will induce a state of insulin resistance. I have several patients like this who require, and they have type 1 diabetes, and they require more than 300 units of insulin per day. And then people with severe systemic infections under the stressful conditions of infection or acute illness can have a double or even a tripling of their insulin requirement. And then there are the rare genetic syndromes, which are defects of insulin action or a defective insulin receptor or a phenotype of lipodystrophy where patients have severe insulin resistance and fatty livers. And these can drive insulin resistance as well. Occasionally, you'll get obese women with type 2 diabetes, with gestational diabetes, and or type 2 diabetes with pregnancy, and the insulin requirement will triple by the end of the pregnancy. And then there are very rare anti-insulin receptor antibody syndromes, but the common scenarios are really at the top of this list. So currently, we have 3 concentrated insulin products, and they are all manufactured by an American company, Eli Lilly. The first is U500 regular insulin, which has been around since 1952. So it's been around a while. And it is an R insulin, which makes it almost intermediate acting more than rapid acting. It's not an analog. It's human recombinant DNA insulin. And this insulin was originally developed for people with insulin antibodies, not for people with obesity-induced insulin resistance, but it's been repurposed because of the obesity and type 2 diabetes epidemic to be, until a few years ago, the only concentrated insulin we had that could meet the needs of people who needed more than 200 units a day. However, as I'll show, it isn't a physiologic insulin in the sense that it has a slow onset and an even slower offset, so it's more like NPH insulin, and it isn't well suited for prandial insulin needs. Then there's U200 Humalog or Lispro insulin, and this is a better, more physiologic bolus insulin because it does have a more rapid onset and offset, a more physiologic profile for prandial insulin use. However, this insulin is only approved for use in injections and not in insulin pumps. And then Eli Lilly also manufactures their ultra-rapid Lispro insulin, which is complex with vasocitrate or with citric acid to accelerate absorption. And this basically is an ultra-rapid acting insulin, which comes in a U200 strength and can be used in injections. However, once again, it is not yet approved for insulin pumps. So here is the pharmacokinetic profile of U500 regular insulin. And here we see on the left, or this curve here, is a rapid-acting insulin analog. This might be insulin Lispro, this might be insulin aspart, this might be insulin glulisine. But at any rate, you can see it is left-shifted to be more physiologic, and it comes on board within a few minutes. It peaks within an hour, and then it has an offset of within several hours. Here is the pharmacokinetic of U500 regular insulin. And it's much more, if you remember, like NPH insulin, where it comes on board, relatively quickly within 60 minutes, but it doesn't peak for several hours, and then it takes 6 to 8 hours in offset. So basically, it has a long tail on it, and this leads to some difficulties using this effectively as a prandial insulin product. So here are its limitations when we try to use U500 regular as a prandial insulin. First of all, its long duration of action gives it an unfortunate potential for insulin dose stacking. And what that means is the one dose of insulin is still on board when the second dose that was taken is coming on board. So you have convergence of 2 doses of insulin, and it has high potential for inducing hypoglycemia. Also, in insulin pump therapy, no pump currently is programmable to do mathematical conversions from one concentration of insulin to another. So we have to program the pump and do the math and divide by 5 for the basals and multiply by 5 for the sensitivity factor and the carb factor, and program the pump for the patient. But if the patient, puts the wrong insulin into the pump that's programmed for U500, they're going to underdose. If they put U500 into a pump that's not properly programmed, they might overdose. So it's been difficult getting approval for these concentrated insulins to be approved in pumps. We need dedicated devices for these concentrated insulins so that people will be safe using them in a dedicated delivery device. And that's why they're only approved in pens right now. And in pumps, you have to bolus 30 to 60 minutes ahead of the meal to use U500 well as a prandial insulin. And basically, you can't even get patients sometimes to bolus 10 minutes ahead because they're not sure where they're going to be eating and they're busy, and you're lucky to get a bolus in there at all. So this is very inconvenient from a patient standpoint. And finally, you can't use U500 very well for correction doses because it's so slow. So some people actually, when they use U500 insulin, either in MDI or in pumps, they actually prescribe a rapid-acting analog as well. And now this is a really complex regimen because they're correcting with one insulin and bolusing with another insulin and putting another insulin in. So it's just too complicated, and it Once upon a time, when it was the only insulin we had that was concentrated, we used it, but that was more a lack of options than a choice. So what about the U200 rapid-acting and ultra-rapid-acting analogs, Humalog and Novolog? I'm sorry, Humalog and Lumchef. Basically, the U200, there is no U200 Novolog. The U200 Humalog does address some of the unmet needs in insulin injection patients who have high insulin requirements. However, once again, it's not approved for use in pumps. But I'll be honest, and I'm sure Davida will address this, we use it off-labelly in pump patients who have high insulin requirements because it's the only way we can practically get enough insulin into the pump for people who need several hundred units of insulin per day. For very high insulin users, we need even a more concentrated insulin. Like I said, I had a gentleman who uses 220 units per day. If a pump cartridge, only holds 200 units, a U200 means he'll still be changing out every day, every other day, or every day. And so basically we need a more concentrated insulin for many of our high dose users. And this will, in injections and boluses, reduce the volume, which will be more comfortable. It could lead to fewer injections per day, depending how you are bolusing this insulin or how you are using this insulin, what kind of a regimen. It will support a trend for longer wear time for pumps because the insulin will last longer in the cartridge. So they can leave it in longer and if the pump cannula can be of a certain design that it can stay in long enough, then this would enable pumps to stay on longer. And finally, and importantly, it will allow us to make pumps smaller because right now they're limited by the size of the insulin cartridge. So it makes them big, clunky things, some with tubing, some without tubing, but they're, visible, and patients really want to have something that's discreet, that's really tiny, that they don't have to whip out in public and everybody sees. So that would be a very nice, patient-friendly way to make pumps smaller. So let's look at U200 Lispro. Now this is a double strength rapid acting analog. And you can see this is an important thing, that the two pharmacokinetic profiles virtually superimpose. This shows basically the PK profile of U200 in red and U100 in Lispro in blue. And this is what you want to see. You want to see that you don't see a big stretched out difference in pharmacokinetics. You want to see that if the parent concentration, which is U100, has an equivalent bioequivalent pharmacokinetic profile, so you can use these interchangeably in terms of clinical efficacy. Ideally, you'd even want it more left shifted, which would mean faster onset, so that it would act more quickly for correction dosing and for meal bolusing. But we'll let Thomas talk about that later. So we did a pilot study a few years back at our site in Asheville, looking at patients using U500 in a pump, which at the time was all we had. And then when U200 Lispro came out, we were very excited because it was more physiologic and we wanted to see what would happen. All we did was take these pumpers, and they were 11 patients, 1 with type 1 diabetes and 10 with type 2, who used U500 insulin in insulin pumps. And they had been stable for 12 months, and they had an average daily insulin requirement of 217 units per day. Their A1Cs were 8%, plus minus 1%. And all we did was we put U200 in the pump, and we had to pull it out of a pen. It's off-label, switch their U500 to U200, and then we just did the math and did equivalent delivery doses. We didn't change anything but the insulin on board time from 6 hours for U500 because of its long time on board to 3 hours for U200 Lispro. And we changed the time of the meal bolus because of the physiology of the the rapid acting analog compared to U500 from 30 to 60 minutes ahead of the meal to right before the meal, 0 to 15 minutes before the meal. And then we wanted to see what would happen to the postprandial glucose just by switching from an unphysiologic to a physiologic concentrated bolus insulin. And what we looked at, we were looking at CGM, we looked at euglycemia, which we defined, this was before CGM really took off, this was in 2016. So we were looking at 80 to 180 milligram per deciliter, not today's metric of 70 to 180, but it was similar. Hypoglycemia, hyperglycemia by CGM, and the total daily insulin doses and the A1C. But what we really were interested in was the peak postprandial at 2 hours. So here's what we found. Just by switching, no difference in insulin dose, same dose of insulin, from an unphysiologic U500 regular insulin to U200 Lispro, look at the lowering in the postprandials. This is after breakfast, after lunch, and after dinner in the evening. And 2 of these were statistically significant. The sugars came down by 25 to 30 milligram per deciliter just by switching to a more physiologic insulin, which shows we need a physiologic concentrated analog for these people. We can't use regular insulin. And in dinner, it came down, but not quite as much. It didn't achieve statistical significance. But the trend was one of improvement in all meals. And here are the CGM times in different range. Basically, there was no difference in hypoglycemia. They were similar and low incidence for both, but we improved the time in range, which we defined as 80 to 180 milligram per deciliter for this study, by 17%. And that came all from hyperglycemia improvement, down from 56 to 38% of time. And this all was because of the postprandial improvement. So why do we need an ultra-rapid U500 rapid-acting pump and pen insulin? Well, think of the 4 C's that I'm showing here. We need it for clinical results. We need rapid-acting insulin to ensure no compromise on especially the postprandial blood glucose and outcomes. We need smaller injection volumes, which will be more comfortable, whether you're taking an injection by pen or a bolus by a pump. The smaller the volume, the less physical discomfort there is and the less leakage at the site of the injection. Smaller volumes are better absorbed. And then for convenience, this would allow us to develop miniature pumps with small cartridges, which will last longer so the patient doesn't have to change out frequently, which of course everybody would like that. And they would get to use fewer pens and have to go to the pharmacy less to replace them, and everybody would like that. And this would also lead to cost savings, because if you are paying for fewer cartridges and fewer pens, it would be cost savings. Plus, in the United States anyway, people have a copay that they have to pay to get their prescription. And if they get more insulin per prescription, it tends to save money. So they get more insulin per copay. And pumps, when they're really running the pump at a high basal and big bolus rates, it runs the battery really fast. So you'll get less battery usage in pumps if you make smaller volume basal and bolus settings, and that would require a concentrated insulin. And this pump doesn't yet exist, but take a look at it. This is the pump of the future. It's really tiny, it's unobtrusive, it's almost flat. It looks almost like today's glucose sensors. And basically, a concentrated ultra-rapid insulin, a U500 ultra-rapid insulin, could meet the insulin requirements of all our patients, even our high-dose patients who are becoming so prevalent. And it could allow for a small, discrete insulin pump, such as this one, with a long duration of wear. So I would propose to you, my colleagues, sometimes size really does matter. And when we're talking about delivering a volume of insulin, you really want to deliver as low a volume as possible for comfort, whether it's in this form or whether it's in injection form. And with that, I will stop and say thank you very much. And I'd like to turn it over to Davida, who is going to tell us about what's going on with patients. So Davida, take it away.
Thank you, Wendy. Let me just get my slides. So what Wendy shared with you, I'm going to show you in case presentations. So everything Wendy showed you is true and real, and is really a problem in when we look at our patient cases. And I only picked 4 cases, but I could have picked you 100 cases of all of the same problem of how do we get creative to meet the needs of our patients. So let me start with, these are my disclosures. And case 1, Mr. G, he's 68-year-old white male diagnosed with type 2 diabetes 22 years ago. He's 5 feet 10 inches. He weighs 253 pounds with a BMI of 35.9. And his most recent A1C is 7.4%. Well, while you might think that's pretty good, he and I have been working together. We started at an A1C of over 11%. And the frustration for both him and, I have to say, as a clinical provider, as his provider, of trying to throw everything, including the kitchen sink, at this man so that we could get him to 7.4. So here are his glucose lowering medications. He is now on U500. He does it by injections using a pen. 25 at breakfast, 25 at lunch, 25 at dinner, and 5 at bedtime. And these numbers may increase depending on what's going on in his day. Keep in mind, this is about 400 units of U100 daily. And that was not working for him for all of the reasons that Wendy just described. I couldn't get good postprandial control, even though U500 is supposed to control both basal and bolus. We were not seeing that. So I had to add rapid-acting insulin, 20 units at breakfast, and then other meals as needed. And you'll see why I tackled the breakfast first. He's also on Ozempic, and you know Ozempic as a GLP-1 does control some postprandial blood glucoses. However, he can't tolerate more than 0.5. It would have been nice if I could have given him a higher dose. That may have helped us as well. And then he's on Jardiance, 25 milligrams, metformin, 500 twice a day. That's his tolerable dose. So if you can look at this, there's 5 copays that this man is dealing with, because I'm still trying to control his postprandial. And just as an aside, he had to go on a steroids for a short period of time, and I had to add NPH to this mix because I couldn't control the postprandials with what I had for the duration that he was on that. So here is his CGM, and you can see even with all of those medications, he's only 65% time in range, still 34% blood sugars are too high, and he does have a little bit of hypoglycemia. Here's my problem. Look at that rise, 6 a.m., and it happens every single day. We've gone through nutrition. We've gotten rid of juice. I've gotten rid of oatmeal because in my 40 years of clinical practice, I still don't know what to do with oatmeal. And no matter what I do, that rise occurs. And so I have added the rapid-acting insulin at a breakfast meal. We're still in the titration phase, but you can see by the lower panel that he is having a little bit of hypoglycemia. I'm assuming that's from the U500, and we're going to have to most likely back off the U500. And I've just gotten his other blood sugars where I'd like it to be. It really is a dance with having to use several types of insulin to try and control this man's diabetes. You can see what's happening at breakfast and the challenges that I'm having with this man. I'm fortunate because he basically will do whatever I ask him to do. He's very good about that. The biggest issue, as you've already heard, is that this medication, U500, really needs to be taken 30 to 60 minutes before the meal. And most people do not have that time in their life, hence why I've added the rapid-acting insulin. This is an ongoing process, and I'm now focusing on getting rid of that rise after breakfast with a rapid-acting insulin. But it's very difficult because how many insulins he has on board, and I've got to think which one is causing the high, which one's causing the low, and where do I take this man next? If I had a more physiological insulin for this gentleman, I think the workload for him and for myself would be better. I'm not worried about me. I worry about the patients and how difficult diabetes is for them, even without these kind of challenges. So Miss C is 58 years old, white woman. She's had type 1 diabetes since the age of 8. And Wendy's already described that we have, when I first started in diabetes, you could tell the difference between type 1 and type 2, normal BMI versus high BMI. That is not the case anymore. This woman is 4 feet, 11 inches, 228 pounds. She has a BMI of 46. And her most recent A1C, it was 8.1%. She's on a Medtronic insulin pump. Here's her basal rates. I'd like you to focus on, first of all, look at how large those basal rates are. Keep in mind, too, what Wendy told you. This pump holds 300 units. Her total daily basal insulin is 117 units. and her average daily bolus is 100 units. That's 200 units per day, which means that this patient is probably changing her site out every day and a half, sometimes 2 days, but every day and a half. Now, so that is, we have to get the extra supplies and the extra workload. And I did try U500 on this woman, and I could not get it to work for her because of her needs of postprandial control. And so we're struggling with the U100 to control her, try and control her diabetes. She is only 55% time in range. And she is the rest of the time mostly high. She has periodic low blood sugars. They're not at any time that I can say, oh, here's where I need to change the insulin dosing. This is her another CGM, and you can see that when she sleeps, we have better blood sugars from midnight to 6 a.m. But during the day, she still struggles with blood sugars. Now, she is taking her insulin about 15 minutes before the meal, but on most days, she is doing a correction factor a couple of hours after eating. So she's got these large basal rates, she's got a pre-meal bolus, and then often when she sees a rise, she'll take it. Now, I'll also say that all of my patients have syringes or pens that they will take a rapid-acting insulin to do correction factors, especially my U500. So if I'm not already giving them a bolus of a rapid-acting insulin, I have given them rapid-acting in a vial or a pen, so that many of them do that for a meal correction because the U500 is not helping. Now, this woman is U100, and so she often does a correction as well. There's another viewpoint of her struggle with her diabetes. And you can see, again, 65% time in range. She's got long-term diabetes. I got to get her A1C down. I've got to get her into range. She has retinopathy and other complications, and I really want to protect her by lowering her A1C as best I can. Okay, here's my case 3, a 31-year-old white woman with type 1 diabetes, diagnosed at the age of 6. She is 5 feet 3 inches. Weight pre-pregnant was 288 pounds, prior to delivery 349 pounds. This is hard, not only from the weight gain, but again, as the change in diabetes and pregnancy that Wendy has described for you, and that the tripling of the insulin needs and the hormones we're dealing with. Her BMI before pregnancy was 40. Her BMI at birth of her daughter was 61.8. Now, we kept her A1C at target for the duration of the diabetes. But let me tell you what we did for this woman, which was the first time in the history of what I've done in diabetes, but was needed. The woman also has, are you ready for this? A needle phobia. So I couldn't get her to take injections away from her insulin pump. And the reason we're successful is because she's on an insulin pump and she only has to change that several days. But during pregnancy, we were running out of the insulin needs. Our insulin needs were way too high, and she wouldn't let her husband give her mealtime boluses away from the pump. So what did we do? We ended up actually giving her 2 pumps. One pump had U500 insulin for her basals. One pump had U100 for her bolus, because I needed the peaking of the boluses to be U100. So this just shows you some of her hourly stuff. We worked really, really hard, and this one was, we got it back down with putting the second pump in. And this shows you her U500 insulin in the pump, which was 64 U100, so times 5, 300 units of U100, if we converted it to U100. And here's her U100. Now you'll see a smidgen of basal, and that's so we could keep it patent, and because she benefited by adding that to the first pump, but then she bolused on this pump, and her basal rates were from the other pump, and that was the only way we could get her A1C below 6% and keep her blood sugars where we needed to keep them, so that we could have a healthy outcome for this baby. And we did, but it was a tremendous products for us, and to be able to achieve this with this woman and the support of both the pump company who provided us, thank goodness, a second pump, her willingness to wear 2 pumps, and our craziness to make that happen for her. Okay, and here's my final case. This is a 47-year-old Black male with type 2 diabetes. He was diagnosed 17 years ago. He's 5 feet 10 inches, 259 pounds. BMI was 27, and his most recent A1C is 7.7. So I struggled with this man. His A1Cs were 10%, 11%. I'd get him down to 8%. They'd go back up to 11%. And we finally put him on a variety of therapies. He's on Jardiance. He does not tolerate the GLP-1 or metformin, which was unfortunate since he has type 2 diabetes. And if I could give him a GLP-1 on top of the SGLT2 inhibitor, his insulin requirements most likely would come down because his weight most likely would come down, but it would help me with postprandial control. And I could not give that to him because he did not tolerate it. His insulin requirements were kept increasing. And so the only option I had at this point was to move him to an integrated pump, and I did use U500. And Wendy made a very good point, is that we're doing this. However, this is not the way the pumps are designed. So we are in our brains recalculating how the pump should manage the patient's diabetes. And when you get to the integrated pumps, it makes it even that much more difficult to say, okay, this is what we want the pump to do. Please look at the CGM and please give this patient. Now, in this man's, when we switch this man over to an integrated pump and we switched him from U100 to U500, you can see that we did see an improvement in his control. I see that this goal here is 70 to 150. And if I changed it to 70, 180, you would see a better time in range for him. But we did change it. We did see a better improvement, and his A1C came down from over 11% to closer to 7.7. I'm still struggling with him for my goals. And you can see during the day where the struggle is. He's not willing to take additional injections away from pump unless the blood sugars are incredibly high. But you can see that from 9 a.m. to midnight, which is when he's awake and eating, that the U500 is failing him in my ability to get him from that 7.7 down to less than 7%. That's the difference between this patient who maybe is close to 8% versus being close to 7% because of the fact that the U500 is failing him in postprandial control. Am I doing better with this guy than the U100? Absolutely. But it's still not giving me the physiological response that this man needs to be successful. And I'll continue to work with him. And he does have a U100 pen, so that if there's times when the blood sugars are really not coming down, he'll use that, but he's not going to use it for all of his meals. Okay. And you can see his basal settings, and he's only taking, it looks like 20 units, but it's 100 units a day of U100. And when I had him on 100 units a day, plus his boluses, he was changing his infusion sets every other day. By moving him to U500, he's, for the most part, only has to change it every 3 days, which was a real bonus, which is another benefit to moving him to U500 and why we opted to do that. Okay, so in summary, you can obviously see the frustrations, and this is just a smidgen of some of the stuff that we're dealing with on a regular basis to try and help these patients get to treatment goal using injections, using pumps, using other therapies, and the realities of what happens, not in just type 2 diabetes, but what's happening to our patients in type 1 diabetes. And so being creative until we can get a more physiological insulin is really what we have to do every single day. So in summary, currently available insulins do not meet the needs of patients with high daily insulin needs, even though we've been super creative with our patients. Humulin R U500 is marketed as a concentrated insulin suitable for basal bolus use. However, it often does not truly control after meal glucose rise, which is one of my biggest frustrations with our patients and trying to control their postprandial. And once I get their diabetes, their A1Cs down closer to 8, if I can't control the postprandial, I can't get those patients under 7%. Often glycemic control is not meeting glucose targets with patients just using Humulin R U500. I have to tell you that I'm using a lot of this U500 because of the nature of my patients, but most of them have other therapies on board, including other insulins, to be able to get them to target and control their diabetes. Rapid-acting insulin in pens or syringes are added for prandial use in patients on Humulin R U500 to increase glycemic control, and complexities of the current treatment programs are not meeting patient needs. And the other issue is that while I'm willing to do this, my colleagues are willing to do this. When the patient steps away from our practice, which is an endocrine practice, a lot of times I have to argue with the pharmacist to fill my prescriptions when they look at the fact that I want U500, U100 rapid. And in the case of my very first patient, when he was on steroids and I had to add NPH, they're like, what are you doing? Please fill my prescriptions, please fill my prescriptions. And then the multiple copays that each of these patients have to deal with, and trying to explain this to other providers is very difficult. So we need something that is much more friendlier to use, and more streamlined for our patients, and more people will get to treatment goal. So I thank you for your time. And it is now my pleasure to introduce you to Dr. Thomas Pieber, who will talk to you next. And then I look forward to you during the Q&A session. Thank you all.
Thank you, Davida, and thank you everyone for this, I would say, fantastic overview of the clinical challenges we have with patients that are needing a more concentrated insulin. So my challenge is now to show you the first results of a new insulin. It's an ultra-rapid, but still ultra-concentrated insulin. And just because the title is so long, I thought to rephrase it and call it just the next step. And that would be to have an ultra-rapid and ultra-concentrated insulin, mainly because the challenges that we have heard just with both talks before really highlighted the medical need. With this slide, I want to show you my disclosures. I want to start then with this quotation, which is coming from almost 100 years ago, from 1925, when those people who had the very first insulins available for their patients, and you remember, we just celebrated the 100 year of the discovery of insulin, what kind of game changer insulin at that time was. And McLeod and Campbell in their textbook in 1925 said, in using insulin, it would, of course, be ideal if it could be supplied so as to imitate the natural process. So there already, there's the concept, and there's the idea that for covering the prandial insulin needs, we need a very fast insulin, and these were animal insulin preparations at that time, and they definitely were not achieving that. So why is it that insulin is so slow when we inject it into the subcutaneous tissue? Well, we're all aware that in healthy subjects, in the normal pancreas, the islets, and specifically the beta cells, are secreting insulin directly into the circulation. And with that, you do get a very peaked curve that's indicated in the blue line here. Whereas regular insulin, and the higher we concentrate it, the slower it gets, has a much slower onset of action and a lower peak, and a peak that occurs much later. And this leads then to several problems that have been highlighted. So there's then a mismatch between the postprandial glucose control and the insulin profile, simply because the insulin is not fast enough. One of the consequences, and this has been highlighted by Wendy and by Davida, are high postprandial glycemic values, which are frustrating for both patients and caregivers. But then also we have the problem that you might have late hypoglycemia, because people tend to correct those postprandial hyperglycemic values, or they tend to overdose. And then overall you are injecting too much insulin, and then hours after your meal, you might run into the risk of late hypoglycemic events. And then one way to compensate or to overcome this problem would be that you increase the interval between your insulin injection and the meal. And this is what patients are doing and what we have to do, for example, if we use the U500 regular insulin preparation that is currently in use. So what are doing short-acting insulin analogs then? Well, they move the profile closer to the physiology. We know insulin lispro, aspart, and glulysin are on the market now for almost decades. We call them usually the short-acting insulin analogs. Actually, the concept behind this, they have a less strong binding that reduces the hexamers, and the hexamers are very stable forms of insulins, I'm showing in a minute. And by less strong binding, they form faster monomers, and the monomers are still the form where when insulin is absorbed in the subcutaneous tissue. The hexamer formation, though, is still strong enough to have a normal shelf life in these short-acting insulin analogs. And one of the clinical consequences of those analogs are lower postprandial glucose control, a better HbA1c control, and that has also been shown in large systematic reviews, less hypoglycemic events, especially nocturnal hypoglycemic events, which at the first thought might be counterintuitive, but it has to do with the long tail of the regular insulin that leads to hypoglycemic events in the late phase of insulin absorption, which after the dinner is then in the night. So the nature was quite inventive when it invented insulin. So the hexamer formation, which is actually caused by two zinc molecules, which are in the middle of 6 molecules of insulin, and stabilize that. That's the way how nature produces it, or natural insulin production occurs in the beta cell. And that's the way how we store our insulin when we put it into cartridges or pens for the shelf life. And there are actually 2 ways to increase insulin absorption. So one is you increase the monomer formation. This is done with the current insulin analogs, the short-acting analogs that are available. And ideally, you would create even monomeric insulin analogs. Another way to increase the monomer formation would be to increase the hydration cell by adding something that gives more insulin around, more water around the insulin molecules, and that also would increase insulin absorption. On the left side, you see ideas and concepts how we can enhance subcutaneous insulin absorption. This is either by increasing the capillary flow, by inducing hyperemia, and one of the latest short-acting insulins are using this concept. You might increase vascular permeability to have a faster absorption, or you might induce vasodilation to increase local insulin absorption. Any measure needs a stable insulin molecule, because if insulin misfolds, it's not active on the one side, and it forms amyloid fibrils, which are inactive and immunogenic. So it's not that easy to modulate that insulin action. And Arecor, a company, has invented a new concept. They call it the Arestat formulation technology, where you improve subcutaneous insulin absorption. What I'm showing here has been published in Diabetes Care last year. It's the U100 per ml formulation of that new concept. So actually it contains insulin aspart in a concentration of 100 units per ml. but it has been designed to increase absorption kinetics of insulin aspart. And in the upper panel, you see the pharmacokinetics. So these are the insulin levels, and on the right side, the pharmacodynamics, which are the glucose lowering effects of that insulin over a full 8-hour period. And in the lower panels, you see a zoom into the first 2 hours. And we can appreciate that insulin aspart, the standard short-acting insulin analog, and faster insulin aspart, a new preparation, clearly differentiate. But this new 8247 formulation shown in green has a substantial earlier appearance of insulin, showing in panel B, and of course, then as a consequence, a faster glucose lowering effect, which is shown in panel D. So this new formulation technology obviously improves insulin absorption substantially. But this was a U100 insulin. I think we have heard excellently just with the 2 talks before why we need not only fast insulins, but also ultra-concentrated, ultra-rapid insulins. And this would allow administration of high insulin doses in a smaller volume. You could avoid splitting of sub-Q injections in people with higher insulin needs. And those patients are increasing, as we just have heard. And you also could utilize and have the advantage of developing a small insulin pump that is more discreet as the current pumps. So the new insulin formulation I'm introducing to you is 8278, and it's a new formulation of an ultra-concentrated insulin aspart. Again, it has been developed by Arecor. It uses the Arestat formulation technology. It has now 500 units per ml, and these are 500 units of insulin aspart. And it has been designed to maintain the rapid-acting characteristics of the U100 8247, where I have shown you the results just before, but using the advantage by reducing the insulin volumes substantially or 5-fold. So the aim of the study that we have performed was to investigate now the pharmacological characteristics of 8278 compared to standard insulin aspart in a concentration of U100 in people with type 1 diabetes. And we investigated pharmacokinetics, pharmacodynamics, and the safety of this new compound. The methods that have been used in that study, which was a phase 1, single-center, single-dose, randomized, double-blind, 2-way crossover glucose clamp study, were the following. So we used a dose of 0.3 units per kilogram body weight of either 8278 with a concentration of 500 units per ml, or an insulin aspart in a concentration of 100 units per ml. We were using syringes to inject that insulin in that study, and dosing accuracy and precision was proved by weighing the syringe before and after the injection, because we have no insulin syringes available for a U500 insulin. We used a euglycemic clamp study, which I will show you the methods in a minute, for 8 hours, and we studied adult men with type 1 diabetes with a diabetes duration of more than 1 year. They were either treated with multiple daily injections or continuous glucose infusion, so pump therapy, and the total insulin dose they were using was below 1.2 units per kilogram per day, and the bolus dose they were using was below 0.7 units per kilogram a day. This shows you the method of the glucose clamp. So the evening before the study day, patients were coming to our clinical trials unit. They were hooked up with an IV cannula to receive regular insulin IV or glucose, depending on the glucose they were arriving with. And then overnight, we slowly were normalizing their glycemia by infusing IV insulin. And this IV insulin infusion was kept until 8 o'clock in the morning. In the last hour, the patients had to be in steady state, so they just were receiving a stable dose of IV insulin, no more glucose. The glucose levels that we were targeting were 100 milligrams per deciliter. Then the new compound, the U500 or the U100 insulin, was injected. And then with a variable glucose infusion, we maintained euglycemia, and the glucose infusion profile that you will see in a minute is then kind of a mirror of the insulin action. And you're doing this kind of glucose clamp studies to avoid hypoglycemia when you test new insulins. And then when glucose was escaping, because these all were C-peptide negative type 1 diabetic subjects, so at some time point when insulin action ended, after injected insulin, glucose started to escape, and then the clamp was terminated. The next slide shows you the study population. So these 38 subjects that we were studying were 39 years old. They had a body weight of 86 kilograms and BMI of 27. So even in Europe, our type 1s are increasing their BMI, as you are observing in the United States. So they were well controlled with an HbA1c around 7 or 52 or 53 millimoles per mole. C-peptide was very low because we were looking for quote-unquote C-peptide negative subjects. And the fasting plasma glucose was 141 milligrams per deciliter, and diabetes duration was high. It was almost 20 years, as you would expect in such a population that has been selected for that trial. So the next few rounds of slides shows you the results of our study. I want to start with the pharmacokinetic studies. So these are the serum insulin concentrations of insulin aspart. So both insulin preparations were containing insulin aspart. The 8278 formulation had 500 units per ml, whereas the insulin aspart, for the standard insulin aspart formulation, contained 100 units per ml. The 8274, the highly concentrated insulin, is shown in yellow. The insulin aspart is showing in gray. On the left panel, you see the full clamp duration, the full 8 hours, and on the on the right side, you're seeing the first 2 hours. And we can appreciate that onset or appearance of insulin of 8278 is much, much earlier than that of insulin aspart, the standard short-acting insulin analog. You also can see that the upswing of the insulin concentrations within the first 10 minutes is substantial. A peak is achieved around 20 minutes compared to 60 minutes or later with our standard insulin formation. So altogether, 8278 showed a faster onset of insulin exposure compared to the standard U100 insulin aspart preparations. This shows you the glucose lowering effect. So it's the glucose infusion rates that needed to maintain euglycemia in the study. As I mentioned before, it's a kind of mirror of your insulin action. And as you would expect, with this much faster appearance of insulin in the circulation, we also see a much earlier onset of glucose lowering effect with 8278 U500 compared to the standard insulin aspart. So 8278 showed an accelerated onset of the glucose lowering effect compared with standard insulin aspart. This gives you a little bit of the statistics. So when we measure the onset of the appearance in minutes, so when is the first aspart seen? So this was 3 minutes in the 8278 preparation and 9.5 minutes with standard insulin aspart, with a treatment difference that was highly significant, as you can see on the p-value. The time to the 50% of the maximum concentration, which is a very good measure of how fast an insulin is getting into the circulation. This was 7.5 minutes for 8278 compared to 32 minutes for insulin aspart, with a treatment difference of 23 minutes, again, highly significant, as you can see on the p-value. When you look at the area under the curve, so totally how much insulin is appearing in the first 30 minutes, you can see this was fourfold higher for the 8278 preparation compared to standard insulin aspart, with a very small confidence interval. So this again was highly significant. And when we look for the first 60 minutes, this was still 54% higher area under the curve of the pharmacokinetic measure in favor of 8278. When it comes to the glucose lowering effect, which is shown in the lower panel, you see the onset of action was around 11 minutes for 8278 versus 21 minutes for insulinaspart, with a treatment difference of almost 10 minutes, again, highly significant. And the time to the half maximum insulin effect was 30 minutes with 8278 versus 60 minutes with insulinaspart, with an average treatment difference of 20 minutes, again, highly significant. And when you look at the glucose lowering effect for the first 30 minutes, this was almost 9-fold higher in favor of 8278. And when you look for the glucose lowering effect for the first hour, this was 2.4-fold higher in favor of 8278. And I just want to remind us, we are not looking as to a comparator like regular insulin or even the U500 regular insulin. We're looking to a standard short-acting insulin analog, which is insulinaspart in its study. We also looked at the total, the peak concentration of insulin and the total area under the curve for the full 8 hours. And this was tested for non-inferiority first, and then for superiority. So we can appreciate the maximum concentration did not differ between the two insulins. None of them was superior, but non-inferiority was significant. And the area under the curve, as you also can appreciate, was very comparable between the two insulins, with the treatment ratios of 0.91 and 0.98, which was not significant in the sense that there was a difference. So superiority testing was a p-value almost close to 1. And same when we look at the maximum glucose lowering effect and the total area under the curve for 8 hours, there was no difference between the two insulins. So to summarize these findings, 8278 is a new formulation of a concentrated insulinaspart with a concentration of 500 units per ml. It showed an enhanced early insulin exposure compared to insulinaspart, with a 6-minute earlier insulin appearance, with a 23 minutes faster half maximum concentration and a 4-fold higher insulin exposure within the first 30 minutes. Furthermore, this insulin has showed an accelerated early glucose lowering effect, 10 minutes earlier onset of action, 20 minutes faster half maximum effect, and a 2-fold higher glucose lowering effect within the first 60 minutes. Overall, 8278 showed the same insulin exposure and the same glucose lowering effect. So what are the conclusions? So 8278 maintains the rapid-acting insulin characteristics in a reduced dose volume. So despite the concentration of 500 units per ml, the fast-acting properties are maintained. Thus, this new insulin preparation has the potential to improve blood glucose management and convenience for people with high insulin needs. It matches the demands of next-generation insulin delivery devices, which have smaller and smaller reservoirs, and you can envision very small pump devices even for children with this concentrated insulin. So when we look into the development of short-acting insulins, we appreciated the benefits of the rapid-acting insulins. We have now the ultra-rapid-acting insulins, and they should better approach the physiologic insulin secretion that we have to replace in type 1 diabetic patients. They might help to replace the early insulin secretion in type 2, and they might have a better profile for pump therapy. So if we have now an ultra-rapid and ultra-concentrated insulin, this should better approach the physiologic insulin secretion for both type 1 and type 2 diabetic patients, independent of the doses they need. It would allow an administration of high insulin doses in a smaller volume. It might avoid the splitting of sub-Q injections in people with high insulin needs. And there might be an advance in the development of miniaturized insulin delivery devices. And with this drawing of a 13-year-old boy who nicely reminds us how delicate the balance between glucose appearance after food intake and our insulin profiles is, I want to thank you for your attention. Thank you very much.
Thank you, Thomas and Wendy and Davida. That was really a great review of this whole issue. And we've got a lot of questions that have come in during the course of things. I'm going to start by, picking it in a couple of questions to put things in perspective. Thomas, you compared Lispro versus the both with AT247 and with AT278 with the rapid acting Lispro, and showed that it was ultra rapid acting. And you drew your drawings of showing regular and how that's slower. But if we go back to what Wendy and Davida were saying, U500 regular doesn't work like regular. It works like an intermediate acting insulin. And that's why they were both using what was basically unrestrained creativity in adding back some more rapid insulin even though they were giving basal insulin by U500. Boy, it was confusing. And the insulins you tested would really solve that problem, wouldn't it?
Yes, so we were comparing against NovoRapid, which is the standard short-acting insulin aspart in our trials. And yeah, that's so we didn't even compare against the U500 regular insulin, which is substantially slower, as you mentioned. So the difference between the U500 regular insulin and the U500 in this new preparation, AT278, is enormous. So the U500 regular insulin is almost an MPH insulin, but it has the advantage of the higher concentration. The U500 of our record, the AT278, is now faster. It seems faster as the fastest insulins currently on the market, but still has the concentration of 500 units per ml. And of course, if you have a pump user, you could easily replace your basal insulin need and your bolus need now with just one device instead of having two devices, as some of the patients that have been presented today were having to use. Because like in a regular pump user, you have one insulin. It's fast if you need a bolus. It gives you a steady basal rate by delivering your small boluses during the basal rates, but you can reduce the volume. And depending on how you design now the new devices, I mean, you can envision pumps that go for a week because with 500 units per ml, the reservoir, the space you need is much smaller than in current insulin preparations.
Yeah. Well, maybe not a week because they're using hundreds of units a day sometimes. So
yeah, absolutely, but depending on the insulin need of a patient.
Yeah,
would it be nice to go more than 24 hours?
Yeah.
You know?
No, the pumps that people are using today with U500, they'd be using them up rapidly. But as you say, if you're using it for a standard pump user, it would really last a long period of time, and that would be great. One other question, Thomas, that was posed was, how close are the profiles of AT278 and AT247? Are they both really the same degree of ultra-rapid action?
Yeah, I mean, these were two different studies, so different patients you never can directly compare, but when you look at the key pharmacological parameters, they seem to be very, very similar, but not identical. I think we will need a head-to-head comparison at some time where you have the U100 versus the U500 of this new Arestat formulation, but overall, we're maintaining the fast profile of AT247, which is the U100. We are maintaining that despite the concentration increase up to 500 units. This is unique because what we have learned in the past is that if you up-concentrate your insulin, it always gets slower. The Arestat technology makes or overcomes that problem, so we can concentrate insulin much higher now without losing the fast-acting properties, which is, I would say, fantastic. After hearing these patient stories and the concepts that have been developed that we're using currently to overcome those limitations. So this is really, to me, a game changer when it comes to patients with higher insulin need.
Sure. And you get it's even ultra rapid. It's even faster than the standard insulin. So that's really good. Pete Meyer has a question, and I guess I'm going to pose this to both Wendy and Davida. He wants to know what will it take for healthcare professionals to be comfortable prescribing a U500 insulin, given the risks of incorrect dosing by patients and incorrect usage, and will it only be really successful in a specially designed pump required to get U500 used?
Well, so I'm not sure if he's asking the way we did it in pumps or if he's talking about injections. So I just quickly say that if it's injections, there are specific pens that the patient doesn't even realize that it's U500, because we just tell them, I'm picking a number, 10 units, and it gives them the concentrated insulin, much like some of the other concentrated insulins that are on pens. So, when I started, you too, Jay, we were saying use a TB syringe or use a U100 syringe and take it, draw it up to this line and blah. But there are syringes specifically for U500 and there are pens specifically for U500. So for those, there shouldn't be an issue, and we should be able to clearly write a prescription that a pharmacist understands and the patient understands. And, outside of my practice in a primary care world, when it's in a pump, that's a totally different story, because we really are making it up as we go along. And I think it's unfortunate. And, we write it up in our notes, we write it up for the patients. And once it's set in the pump, all the patient has to do is add it to the cartridge. So that's not a problem either. I think we can pull this off if we have to. It's just not giving us what we need physiologically.
Yeah, I would say I agree with Davida. It's easy in a pen because you can just set the pen for that strength of insulin. There actually are concentrated insulins in pens that do this, so you don't have to worry about it. Just dial unit per unit and it's identical. But what we would need for pumps, and this is where we have to get not just insulin manufacturers involved, but pump manufacturers involved, or get somebody to do both. But basically, you need a pump that is dedicated for just that concentration of insulin, or you need a pump that you can program. Like when you're programming it, there will be like the first screen will be something like what concentration of insulin. But even that, the FDA in the United States feels uneasy about, because they're afraid patients may mix up which insulin they put in. So the safest thing to do will be to do dedicated pumps that only can deliver concentrated insulin. They'll have to be flagged as such, like a different color from the other pumps. Like a U100 pump will be blue, and a U200 pump will be a certain color, and a U500 pump will be a different color. And so you couldn't mix them up. And what I envision besides a small pump is a pre-filled pump. So the patient doesn't even have to get involved filling it. It's already pre-filled, and this would likely be disposable pumps, such as the Omnipod. But at any rate, you would purchase the pump pre-filled with the concentrated insulin product. The pump would be dedicated for only that concentration, and then everything that you would read, like when you would see the units on the display or on your phone, whatever your device is, would be in actual units, not pump units. In other words, if you were taking 50 units, it would show up as 50 units, U100, U200, or U500. And the volume in the pump, of course, would be different. The pump would be smaller, but it would be unit per unit. We'd always read the same amount. So nobody would be confused between providers or medical records or that kind of thing.
So Bernie Warren wants to know, for those who are using insulin pumps in your practices and in your research, did the pump placement make any difference in terms of the absorption of the rapidity of the insulin, such as abdomen versus arms and so forth?
Well, I think as a good clinician, we always go in and look at sites, touch sites. It's not enough to look at sites. You have to touch sites, whether the patient's on a pump or an injection. And once you feel lipohypertrophy, you'll know what it feels like. And if you look at a patient, you can see the puffiness if it's there. So from my perspective, once I've done an inspection, and I will do that ongoing, as long as I'm using good tissue, it doesn't matter whether it's the stomach or the arm, as long as it's subcutaneous in tissue. And the good news is if it's U500, it's a smaller volume. The bigger problem, and if it's a pump, typically it's going to be a small volume anyway, it's the patient who's injecting U100 in large volumes that is a problem. And I think the bigger problem is not whether it's a stomach or an arm, but I'm going to pick a number. Let's say the patient's going to do 60 units and they're going to use a pen. You got to make sure the pen is into the subcutaneous tissue and that they hold the pen long enough after they suppress the pen or the syringe so that it has the time, and they don't do it too fast so that the absorption is there. So again, I don't think it's picking good tissue and good technique and understanding that at some point that volume is just too much for the skin to really do a good job in utilizing what we're giving it.
Yeah.
So
just adding to what has been said. So currently the U100, the new Arecor insulins only have been tested in the abdomen. So we didn't test arms and thighs or anything yet. I think in the past people spend a long way to find out if there's a difference. I think the faster insulins get, the less relevant that is, because the Arestat formulation just changes the behavior of the capillaries transiently, and that allows a fast absorption, and that should work in all body sites. But formally, it hasn't been tested yet. So in our study, we're using a very standardized way to make sure we exclude any confounding factors.
So one person has asked, you talked about, a pump that would last longer because you're able to use the concentrated insulin. And this person wants to know, how long will these concentrations of insulins be stable at body temperature or at room temperature as you're infusing them, and will that become an issue?
Yeah, we don't have the full answer yet, but these tests are currently ongoing. So Arecor and we are working together with some pump manufacturers to get a new small pump available sooner than later. I think that's what patients will need. And stability at room temperature and stability at body temperature is an issue, especially if you move a lot around. We all know that if there is small air bubbles, that insulin might unfold and become a fibril and inactive. So this needs to be tested. The current data are supporting that it will be stable, but it hasn't been published yet, so we have to wait for those results.
Great. Lara Gregoric from the UK, has a question for our US people about use of these things, because you both brought up copays. And she says it may be naive because she's from the UK, but how important is patient copay in determining the clinical adoption by healthcare professionals of anything you prescribe?
It's humongous, humongous. We have zero control over the copay. Right now, I'm working with a person who has type 1 diabetes, and for 4 vials of insulin, it's $167 after is what is insurance, and I've done everything I can do. And then if he has 2 or 3 or 4 other, and on an average, a patient with type 1 diabetes has 7 to 11 prescriptions per month with copays. I just did a thingy thing to look at that. And so it's huge.
What is a thingy thing?
A thingy thing is when you go and look at the Epic and you pull out the thingy thing so you can say, look, this is why we're going crazy. But it's huge in the United States. The other thing in the United States is annual deductibles. And every January, many of our patients have anywhere from $1,000 to $6,000 or $8,000 deductibles. That's out-of-pocket cost. So they're paying everything up front cash. It's a huge problem in the United States. So if I give patients 5 or 6 medications to control their diabetes because I don't have an option to use 1 or 2, the follow-through can be difficult. I showed you 4 patients who really jumped through every hoop and do whatever I can tell you, but I can tell you there's plenty of them will say, pick 2, Davida. That's all I'm going to do. That's all I can afford is 2. Which 2 is it going to be?
Oh, makes it really tough, doesn't it?
Yes.
So one person wants to know if you're giving concentrated insulin to a type 1, will that make them gain more weight than an unconcentrated insulin?
Yeah, I'll take that. So with U500 insulin, we did see more weight gain because in the patient population we use it in, they probably were not adequately controlled with U100 insulins. So, anytime you improve the glycemia, you're going to see some weight gain. But ideally, if you are doing the same insulin dose and just switching the concentration, whether it's U100, U200, or U500, it should induce the same lipogenic effect once the glycemia is controlled. And, this is a population of people who have a weight problem in the first place. So basically, you want to do everything to minimize, especially in people with type 2 diabetes or type 1 diabetes, if you can use insulin sparing agents, which of course in type 1 diabetes are off-label, such as the SGLT2 inhibitors. You want to do that to minimize the weight gain associated with insulin use. But, we're between a rock and a hard place. We have to control the glycemia. These people need a concentrated insulin to do so. They were uncontrolled with a U100. We have to use a concentrated insulin to get them under control. There's going to be some further weight gain, and then you have to jump through all the hoops to try to do whatever it takes in anybody to minimize weight gain. Diet, exercise, insulin-sparing agents. Many of my people with type 1 diabetes have had gastric bypass surgery with type 1 diabetes, not so much just to get their insulin requirement down. I was able to control their type 1 using concentrated insulins off-label in pumps, but they were morbidly obese. They just were unhealthy. So they are still getting gastric bypass surgery. So you do everything you can, but you don't let that deter you from getting the diabetes under control. You manage the weight as a separate issue, however you will do so. You use GLP-1 receptor agonists, do whatever you need to do.
Mm-hmm. Absolutely.
One question here is from a person who's not used these, wanted to know, how is HCP acceptance of U200s and U500s, and particularly if you're talking about primary care? Do they really understand that there's a difference, and how do they manage that?
Simple answer. Yeah, the simple answer is no. That once you walk out of, it's really hard. Once you walk out of endocrinology, it's really hard for primary care to understand. What do we have, like 11 classifications of drugs now? It's not just sulfonylurea and insulin, which when we first started in diabetes, all you had was long-acting sulfonylureas, and then you jumped to insulin. So they're used to basal insulin, not as comfortable with short-acting insulins, certainly not comfortable with a concentrated insulin. And I think within endo practices, so we're all comers. We take whatever there is out there to manage the diabetes. But I do think that's the future of diabetes. And so we need to get that message out to our colleagues who actually manage more of the diabetes, and certainly in the type 2s, than we do in endocrinology.
So, what we've really seen here today is that there are two separate problems. One is people who need high doses, and so we need to have a higher concentrated insulin for that. And the second is that the historical available high-dose U500 insulin doesn't work rapidly enough to be able to be used for prandial or correction doses. It can provide probably a nice basal background if you're using it in a pump, but it doesn't solve the other problem of needing the rapid activity. And what Thomas has shown us is with these new preparations, you actually can get the rapid activity and still have the high concentration. And I think that is really the thing that we need to appreciate here, that it's solving two problems at once, and would be really great. But I think that what it dictates too in the long run is that, and you've all mentioned it, is that we're going to be looking for specially designed pumps that have pre-filled cartridges. We want to get rid of patient confusion, and that are programmed for using the higher concentration so they can use it in the same kind of way historically that we've used U100 in standard patients for pumps. And so, and even in the standard patients, this might be useful because they might have to change their pump site less frequently. So it could have potential use across the board like that. Is that a reasonable interpretation of everything you've told me?
Yes,
absolutely.
Yes.
And we just got a question in at the last minute here. said from this attendee saying he or she gets the feeling that the panel really does see both the formulations as a major breakthrough, and is that they want to know if that's really the case, or are we just kidding? I think we're really saying yes.
We're too old for just kidding. Yeah,
I wouldn't be here if I was kidding.
Right. We're excited about the opportunities for our patients and our ability to provide better care, actually. Absolutely.
Yeah.
Yeah, I also want to add that when we were testing that insulin, that was like almost unbelievable, because you're blinded in this kind of trials, but you're realizing you expected the U500 to be maybe as fast as Aspart, and it was so much faster that
That's amazing.
I mean, patients immediately also saw what the advantage is. So this is a product that patients and caregivers, nurses, doctors, everyone is waiting for now for decades. I mean, it seemed not be possible, and these new formulations make it possible. So that's really fantastic times right now.
Yeah.
Yeah, great. Well, anyway, I've really enjoyed all three of your presentations. I spend most of my time with type 1 diabetes. And, Wendy was pointing out how these type 2 patients who are so overweight need to be on this kind of insulin too. And I have given that less thought, because that's my, I have the odd kind of practice where 90% of my patients have type 1 because of my research interests. And so, it really has opened up a lot of new thoughts from all the things you said. And DeVito, patience, and how she again had to use unrestrained creativity. You know where the words unrestrained creativity come from? It was the DCCT presentation in Las Vegas in 1993, when the commentator, who was Dan Foster, said that he was the independent commentator, said that what the success of the DCCT was their ability to do unrestrained creativity in the treatment of patients. And here too, you've had to again lean on unrestrained creativity. And I think that's an important thing for specialists to always have in trying to manage the vagaries of different kinds of patients with type 1 and type 2 diabetes. So it's been really a useful panel for me to see that. I want to tell the audience that if they want to see it again, or if they have colleagues that want to see it, the presentation is available on the ATTD education website, which is www.att-education.com. I want to thank everybody in the audience for joining. It's been a really delightful time for us. And there's also up here a way to get in touch with Aracor if you want to learn more about their insulin. But I want to thank everyone, the panel, for being with us. Thank all of you, the attendees, and hope to see you again soon. Bye-bye.
Bye, everyone. Thank you.
Bye. Thanks.
Bye.
Have a good